Welcome to the Ellsworth County Medical Center's Heparin Protocol Learning Module. This learning module will provide an overview of Ellsworth County Medical Center's heparin protocol with a definition of heparin, common uses, kinds of heparin, possible adverse effects, monitoring, and safety guidelines. Finally, we will review the calculations for filling out the clinical algorithm on the ECMC heparin protocol worksheet. Today, we will be going over heparin. Why is this important? Because we see this medication often, and many nurses are never comfortable with it. We understand that any anticoagulation medication is a high-risk drug, and there is a very small window for therapeutic dosing. Too much can cause bleeding, and too little may lead to clotting. Heparin is a medication that requires close monitoring to avoid adverse effects. Unfractionated heparin also requires timed lab tests for dose titration. Both unfractionated heparin and low molecular weight heparin require vigilance for potential drug and food interactions. Brushing up on this medication, becoming more knowledgeable and comfortable with it, is always a good idea. Let's start with the definition. Simply stated, heparin is an anticoagulant that prevents the formation of blood clots. Heparin is used to treat and prevent blood clots in the veins or arteries. Heparin is also used before and after surgery to reduce the risk of blood clots. Heparin is used to help keep open and maintain access ports for therapeutic treatments. It is also used to create an anti-clotting surface inside various medical devices such as renal dialysis machines and test tubes. Heparin is naturally produced in the body by basophils, mast cells, and other tissues. Pharmaceutical-grade heparin is derived from the mucosal tissue of animals that have been slaughtered for meat, such as pigs and cattle. Research conducted between 2003 and 2008 eventually led to the synthetic development of low molecular weight heparin in 2011. But to truly appreciate heparin, you really need to understand what it treats. Blood clots. There is a complicated flowchart called the clotting cascade that describes the formation of clots in mind-numbing detail. Don't panic, we're not going into that today. Simply stated, a blood clot is formed when there is direct damage to a blood vessel. This exposes platelets in the blood to collagen from the surrounding tissue. Platelets and collagen bind, forming a platelet plug. During this process, platelets are trapped and stabilized with cross-linked activated fibrin. This mechanism of fibrin formation is then controlled by other clotting factors that both promote and inhibit clotting. You see, the body is always working to keep everything equal, maintaining a balance. If the ability to preserve this balance is disturbed, the patient will have a bleeding problem or conversely a clotting issue. Now, as we said before, our problem is blood clots and how to treat them. So if a patient has a high risk for clot formation, there are various drugs available that work on different areas of the clotting cascade to disrupt the clotting process. There are three main types of drugs routinely prescribed in blood clot management: anticoagulant drugs, antiplatelet drugs, and thrombolytic or fibrinolytic drugs. Anticoagulant drugs. These are for patients with a tendency to form clots in the slow-flowing blood of the venous system, but they can also be used to treat or prevent clots in the arteries, brains, or lungs. These drugs have the ability to stabilize an existing clot so that it does not break away and become a circulation-stopping embolism. But this kind of drug cannot actively break down a clot. Heparin is in this category of drugs. Antiplatelet drugs. These drugs are for patients with a tendency to form clots in the fast-flowing blood of the arterial system. Antiplatelet drugs reduce the ability of platelets to stick together when the blood flow is disrupted, thereby reducing the risk of clot formation. This group includes aspirin, Plavix, Riopro, and Aggrastat. We will not be covering these medications today. Thrombolytic or fibrinolytic drugs. These drugs are for patients requiring emergent breakdown of a clot that has already formed. These drugs are administered intravenously at the hospital following an acute blockage of a blood vessel within the heart, lungs, or brain. This group includes drugs such as alteplase, retaplase, and streptokinase. We will also not be discussing these medications today. Today, our focus is heparin. Heparin is an anticoagulant used to treat or prevent clots in the veins, arteries, lungs, or heart. It stops clots from forming or getting bigger. Heparin also helps prevent clotting during open heart surgery, dialysis, or in patients who are confined in bed. It is prescribed for patients with acute coronary syndrome, atrial fibrillation, or during an acute MI. Heparin is also used for indwelling catheters to assist on keeping them clear and open. There are two kinds of heparin, unfractionated heparin and low molecular weight heparin. Unfractionated heparin has been used for the prevention and treatment of thrombosis for several decades. It's a natural polysaccharide with variable lengths and molecular weights. Its anticoagulant effects and pharmacological properties vary with the size and weight of these molecules. Unfractionated heparin has limited bioavailability because it binds to plasma proteins, platelets, macrophages, and endothelial cells, resulting in a highly variable anticoagulant response. It requires regular labs to monitor its effects and is primarily given intravenously. Low molecular weight heparins, in contrast, consist of only short chains of polysaccharide. These short chains are obtained by various methods of fractionation, a separation process in which a certain quantity of a mixture is divided into a number of smaller fractions. Fractions are collected based on the specific property of these individual components. Low molecular weight heparins are made from unfractionated heparins. Each low molecular weight heparin product has a specific molecular weight that determines its anticoagulant activity and duration of action, so one product cannot always be substituted for another. Low molecular weight heparins are in current use globally, including enoxaparin. Low molecular weight heparins are administered subcutaneously for VTE prevention. They have a more predictable dose response and have fewer non-hemorrhagic side effects than unfractionated heparin. Low molecular weight heparin doesn't typically require labs to monitor its effects. Because of several clinical advantages, low molecular weight heparins have gradually begun to replace unfractionated heparins for many indications. There are several advantages of low molecular weight heparin over unfractionated heparin: longer half-life, higher bioavailability, a predictable dose response, and decreased risk for heparin-induced thrombocytopenia. Bleeding is the most common side effect of administering heparin and may present in a variety of ways: epistaxis, gum bleeding, hemoptysis, hematuria, melena, and hemorrhage. Undiagnosed and uncontrolled bleeding may lead to cardiovascular collapse or cardiac tamponade. In event of major bleeding, heparin should be stopped immediately, and if necessary, protamine sulfate may be administered. A serious side effect of heparin is heparin-induced thrombocytopenia, an antibody-mediated reaction that targets platelets, resulting in platelet degradation, causing thrombocytopenia. This is a potentially life-threatening condition and causes thrombosis in approximately 50% of affected patients. Treatment involves discontinuation of all heparin products, including flushes. Caregivers should carefully document any history of HIT, and patients should be educated to inform all providers of a HIT history. Two non-hemorrhagic side effects of heparin are known as elevation serum aminotransferase levels, reported in as many as 80% of patients receiving heparin. This abnormality is not associated with liver dysfunction, and it disappears after the drug is discontinued. Hyperkalemia occurs in 5 to 10% of patients receiving heparin. It is the result of heparin-induced aldosterone suppression. The hyperkalemia can appear within a few days after the onset of heparin therapy, and more rarely the side effects alopecia and osteoporosis can occur with chronic use. Heparin requires close monitoring because of its narrow therapeutic index, increased risk for bleeding, and potential for heparin-induced thrombocytopenia. Monitoring includes thorough head-to-toe patient assessments for potential side effects and laboratory monitoring. Laboratory monitoring typically includes measurements of coagulations such as activated partial thromboplastin time, prothrombin time, plasma heparin concentration, whole blood clotting time, activated clotting time, plus a complete blood count to monitor platelets and assess for bleeding. The APTT is most commonly used as a global measure of a patient's overall anticoagulation. Please note that an APTT is an indirect measurement and can be affected by many factors such as lupus, anticoagulants, factor 12 deficiency, activated procoagulant factor 8, liver diseases, and medication interactions. Nursing assessment for the patient with low molecular weight heparin is the same as for the patient on unfractionated heparin. However, laboratory monitoring is rarely required. Anti-SA low molecular weight heparin monitoring may be ordered for specific patient conditions such as obesity, small stature, impaired renal function, and pregnancy. A nurse-driven heparin protocol for IV heparin administration is used here at ECMC to manage many patients' anticoagulation needs. Providers order a heparin therapy anticoagulation target, and nurses use a clinical algorithm to guide care. Nurses obtain baseline labs, calculate and administer initial bolus doses, order and evaluate anticoagulation labs, and titrate heparin to a therapeutic goal based on the clinical algorithm and patient presentation. Laboratory monitoring involves obtaining and evaluating labs every 6 hours after a dose change until 2 consecutive lab results are within target. Once target anticoagulation is achieved, these labs are then monitored once daily. Filling out the ECMC heparin protocol worksheet correctly is very important. Usually the supervisor will take the order. Fill out the form and confer with the pharmacist on the calculations, but sometimes it will be up to you. That is why it's essential for you to understand these steps. The first thing to know is the patient's diagnosis and what side of the form to use. The front is for DVT and PE patients less than 70 years old. The back is for cardiac and all other patients greater than 70 years old who will be receiving heparin. Also, routine labs are on this form for each diagnosis. Be sure to check for extra orders from the provider. Next, you will need the patient's weight in kilograms. You need this information for both the bolus and the IV maintenance infusion. At this point, you can begin the calculations for the bolus amount and the maintenance IV infusion rate. First, calculate the bolus amount by the patient's weight. For DVT or PE, the protocol states that the bolus should be 80 units per kilogram. Convert the patient's weight in pounds to kilograms and then multiply the result by 80. Round your result to the nearest 500 units. When you get your bolus amount, write it onto the protocol sheet. Next, calculate the maintenance infusion rate by the patient's weight in kilograms. For the VTE or PE protocol, they want 18 units per kilogram per hour. Use the converted to kilogram rate from the bolus calculation and multiply it by 18. The results will be your units per hour. Take the results of the units per hour and divide by 100 to equal your milliliters per hour. Write both of these results on the protocol sheet. For cardiac patients or other patients, including those greater than 70 years old, the process is similar. The protocol states that the bolus should be 60 units per kilogram. Convert the patient's weight in pounds to kilograms and then multiply the result by 60. Round your result to the nearest 500 units. When you get your bolus amount, write it into the protocol sheet. Next, calculate the maintenance infusion rate by the patient's weight in kilograms. For the cardiac protocol, they want 12 units per kilogram per hour. Use the converted to kilogram weight from the bolus calculation and multiply it by 12. The results will be your units per hour. Take the results of the units per hour and divide by 100 to equal your milliliters per hour. Write both of these results on the protocol sheet. To make it clearer, we have an example of a DVT patient weighing 200 pounds. 200 pounds divided by 2.2 equals 90.9 kilograms. Lotus protocol states 80 units per kilogram with a maximum of 10,000 units. Round to the nearest 500 units. 90.9 kilograms times 80 units equals 7,272.7 units. Rounding it to the nearest 500 units is 7,500 units bolus. IV infusion protocol states 18 units per kilogram per hour, with the maximum rate of 2,000 units per hour. Round to the nearest 50 units. So 90.9 kilograms times 18 units equals 1,636.2, and rounding it to the nearest 50 units is 1,650 units per hour. Enter a rate as units per hour divided by 100 to equal milliliters per hour per protocol. So 1,650 divided by 100 equals 16.5 milliliters an hour. Finally, we will enter the circled results onto the protocol sheet. Here is the cardiac patient weighing 150 pounds. 150 pounds divided by 2.2 equals 68.18 kilograms. Bolus protocol states 60 units per kilograms with a maximum of 4,000 units, rounding to the nearest 500 units. So 68.18 kilograms times 60 units equals 4,090.9 units, which is above the maximum 4,000 units, so we give 4,000 unit bolus. IV infusion protocol states 12 units per kilogram per hour, with a maximum rate of 1,000 units per hour. Round to the nearest 50 units. So 68.18 kilograms times 12 units equals 818.16 units. Rounding it to the nearest 50 units gives you 800 units per hour. Enter the rate as units per hour divided by 100 to equal milliliters per hour per protocol. So 800 divided by 100 equals 8 milliliters an hour. We will enter the circled amounts onto the protocol sheets. Remember, it's important to completely fill out the heparin protocol sheet. You will need the patient's weight in kilograms, the IV bolus amount, and the IV infusion rate in both units per hour and milliliters per hour. But even more important, have all of your calculations checked by either a supervisor, pharmacist, or another nurse, and document. As with everything, documentation is key. Remember in nursing school when they always said, if it's not written down, you didn't do it? They're right. Surveyors will look for the correct documentation with any administration of heparin because it is such a high-risk medication. Document start, reviewing labs, patient presentation, do this often, and any changes. Make extensive nurse's notes when you change the rate and explain fully why. Include the actual calculations so there is never any question. In conclusion, heparin is an anticoagulant used to treat or prevent clots in the veins, arteries, lungs, heart, or brain. Heparin is used to help keep open and maintain access ports for therapeutic treatments. It is also used to create an anti-clotting surface inside various medical devices such as renal dialysis machines and test tubes. There are two kinds of heparin, unfractionated heparin and low molecular weight heparin. Bleeding is the most common side effect of administering heparin and may present in a variety of ways, so close monitoring is required. Filling out the ECMC heparin protocol completely and documenting thoroughly is very important. Included in this module are sample questions to help you feel more comfortable with calculating the required dosages of heparin. Our goal is to make you more comfortable the next time heparin is ordered on your shift. Thank you for your attention, and remember, if you have any questions, please do not hesitate contacting me.